Well, thank you so much for invitation. I'm talking about the Trochleoplasty osteotomy Tunnelless MPFL reconstruction. Thank you so much for the invitation. So this university is really nice. I love it's like in the forest, really nice, and this is autumn time, colorful. And yesterday I had the chance to go to Moscow State University. Yeah, thank you Vladimir for bringing me there. Okay, and thank you my personal translator. Yeah, because I cannot understand you, she translates everything to me. Thank you so much. So the patella instability is very complicated. You need to understand the picture, but it looks so complicated. I will make it simple, okay? So before you treat the patella instability, first you need to know that bone is very important. So bone containment and bone alignment is very important. Like Dr. Andre told you that you need to know everything about the ankle, patella alta, trochlear dysplasia. So if there's abnormal bone problem, you need to solve the bone first. If you solve the soft tissue, it will be failed. You need to fix the bone. So for the alignment, you need to fix the anteversion. This is more than 25, genuine vacuum more than 10, TT-TG ratio or TG-PCL ratio more than 20 or 24. So these things you need to fix it first. Take this picture, this is very important. And then you can soft tissue balance later. Okay? If you have tight lateral, you need to release. The lateral retinaculum is the lateral tilt more than 20 degrees, or you have neglected dislocation. But if you have dynamic J side or jumping J side, that means you have problem of the medial patellofemoral ligament. Examination, first you need to look at the J side. Let the patient sit and then flex extend, okay? You see that this patient, I think already this side is good. This side you have some J side, but this one is jumping J side. Whenever you have jumping J side, thinking about the bone. It's not just soft tissue, you need to fix the bone. If you have jumping J side, keep in mind. If you fix the soft tissue, it will be failed, okay? And if the shaking the patella, gliding patella apprehension, if the patella very loose, okay, thinking about the soft tissue problem, genuine vacuum like this patient have valgus deformity. If you just fix the soft tissue, it will be failed. You need to make a distal femoral osteotomy. Patella tilt more than 20 degrees, you need to release the lateral retinaculum. Okay, you have too much anteversion of the hip more than 25 degrees, you need to solve the osteotomy. Yeah. And always looking for the Beighton score. If the patient have very loose, okay, Beighton score, thinking about the soft tissue problem. Yeah. So that is the examination. Yeah. X-ray, Andre already told you, right? You need to remember everything, and you need to make a good measurement. Carton de champ is standard, more than 1.3, and you have trochlear dysplasia type B or type D. You need to do the trochleoplasty. CT scan, okay, looking at the lateral tilt, more than 20, okay, or the TT-TG more 20, that's you need to collect the bone also. Yeah, this is the CT scan of the hip, is at more than 25 to 30. So these numbers you need to remember before you jump to do the soft tissue surgery. And this is the geoclassification. Type B and type D need the trochleoplasty. Typical osteotomy, you're looking at the TTG ratio, okay, 20 and 24. So nowadays the TT and PCL become more popular, right, Andre? Yeah, it's become more popular, yeah, more than 24, right? These two numbers you need to remember. Yeah, if you have problem, you need to do some medialization or antromedialization, M3 or Ferguson osteotomy. Okay, this patella alta, you need to do distalization to collect the CD, carton de champ to be 1.1. For the femoral osteotomy, yeah, if you have too much anteversion, more than 25 to 30 degrees, you need to collect it to be 10 to 15 degrees. This is normal. And we prefer to do the distal. You can do proximal, middle, or distal. But distal is easier because you can collect the axis. You can do the valgus osteotomy at the same time. You can collect coronal and rotational osteotomy, and this is heal faster because this coarse weight osteotomy, okay, and rapid weight bearing. Yeah, we prefer to do distal osteotomy. And when you do the distal femoral osteotomy, you can also collect the TTG distance, patellar tilt, and patellar engagement. Okay. Trochleoplasty, if you have bad trochlear dysplasia like type B or type D, you can do this way. The trochleoplasty, this way, But it's a bit invasive, So nowadays we have more or less invasive, the arthroscopic way to do the trochleoplasty. You can do the arthroscopic trochleoplasty using arthroscope, right? That is less invasive, So soft tissue. Now we're talking about soft tissue. MPFL is not isometric. It's tight when extending. At 0 to 30 degrees. This is a function of MPFL. But when you bend the knee, it's become loose. So MPFL is not isometric. Okay. So tight in extension and loose in flexion. So previously we use a cementinosis, make a tunnel. But the problem is when you make a tunnel, you can break the bone. So nowadays we move to soft tissue without tunnel in the patella. So this is my literature. I published this technique about the soft tissue reconstruction without bone tunnel. So the good thing is that you can have no tunnel, just mid one screw for the femoral side. So this is another article. We found that the patient have same outcome if you use a quadricep or use a hamstring. We call this tunnelless MPFL reconstruction. The good thing is that you can use in small patella in the immature patient, okay? Like this one, you see that? This is our way. We use a quadricep to make an MPFL. It's attachment on the proximal third is more anatomic, and also you have pulling and flipping effect at the same time. This is less invasive. You see, you have only one incision and one small hole. Less pain and better outcome. So we put the internal breast into my MPFL too. We found that the outcome is better. Okay, you have less failure rate, only 2% comparing to 23%. So this is my MPFL reconstruction. Okay, so using the quadricep tendon, only one incision, less problem. So now we're talking about the techniques. So we position patient this way, okay, and then we strip the MPFL. This is a superficial layer, is a rectus femoris, okay, and then you strip it that way, and then graft preparations, suture. So we need the length about 9 to 10 centimeters. I think for Russian people, you're big, you have no problem, you have longer quadricep, right? But in our Asian people, sometimes we have shorter quadricep, right? And then the key point is that you need to strip your patella very gentle, your quadricep from the bone like this, So after that, you flip it 90 degrees and make a tunnel underneath the vagus midilis, right? And then you make a tunnel above the capsule, okay? And then you pass your graft into this tunnel. Then I suture my my graft to get to the periosteum like that, okay? And after that, you secure it and using the tape, right, into your patella. And this tape, you act like the internal breast, And then we pass the tape into the patella like this. So you see your patella will be stronger, like this. So tendon and suture together make it stronger. You have less problem, So the graft should be about 9 centimeters and find the shuttle point, okay, make a tunnel and pass the graft into the tunnel, okay? And then you also check your patella alignment after you put this fixation. Your patella should be in the center like this. So always put the camera in the joint to check the patella, okay? And fix the screw at 30 degrees, okay? Not in extension. You should fix it about 30 to 45 degrees, okay? So an example, this is a 15 years old, got patella dislocation. He has a high Biden score, okay? So his problem is that he have a TTTG 24, okay? And also has a really a bit tilt patella. We need to do the tubercle osteotomy anteromedialization, okay? After we medialization of the tubercle, then we doing the MPFL reconstruction, okay, using the quadricep, okay, like that. Okay, fix the screw at 30 degrees. Yeah, and check every time when you put the screw, you need to check. Yeah, this is an X-ray after surgery, and the patient doing well. Okay, after the surgery, this is about a year after surgery. She has good function. This the second patient, 32 years old, she had trauma. You see, she has a fracture of the patella. So she is very young. So I need to save her cartilage by putting this cartilage onto the patella by fixing using the osseous technique, right? So this is very simple. You use a absorbable white crew, right, and fix your patella back, okay? And after that, you doing the MPFL reconstruction. I put the tape together with my graft, okay, stripping this way, repair it, okay, and then fix it this way, yeah. Okay, this is after surgery. So this is a follow-up, yeah, about 2 years after surgery. The patient doing well and she has good function, good range of motion, yeah, and go back to sports. So the last patient, this is the 26-year-old, she had patella dislocation. You see that she has the valgus deformity, right? And patella is dislocation in flexion. So that means the patient have very tight lateral retinaculum, just also femur anteversion more than 30. So we have to do the lateral release first, okay? First, we get in and do the lateral release using arthroscope, okay? Release, and then we check the patella mobilities after release. The patient have better patella mobilities. And after that, we're going to do the rotational osteotomy, okay? So this way, we're going into the femur and then we calculate. This patient have 30 degrees. I need to correct it to 15 degrees. So my correction is 15 degrees, right? And then we rotate. At the same time, we change the valgus, okay? So this is the two-plane correction, coronal and rotational correction, okay? So that is after the derotation osteotomy, okay? And after that, we do MPFL reconstruction, yeah? So using the quadriceps, this is rectus femoris, okay? Do it very gentle and go underneath the valgus medialis, right? Fix it at the shuttle point, check the stability, okay? Fix it this way, okay? So it's a bit invasive because you need to correct everything, the coronal alignment, rotational alignment, MPFL, and check with the arthroscope that the patella is in the center after the fixation, okay? So post-op, we let the patient start to motion, okay? And she's getting much better now. The patella is in the center, okay? And she's quite happy, right? Good motion, yeah, yeah. And good quadriceps come back. She is good now. So in conclusion, you need to remember this algorithm, right? It's a bit complicated. Starting with bone first, collect the bone alignment, bone containment, okay? And then soft tissue. So soft tissue for me, I prefer using quadriceps, tunnelless. We did not make a drill hole in the patella because you have no chance of fracture. This is safe, reproducible, and once incision. And I recommend that for the very small patella and also immature patients. Thank you so much. And that is my WhatsApp. Add me to be your friend. WhatsApp. Thank you.